All right, Dr. Callewart, thank you for taking some time to speak with me and learn a little bit more about you and
Sure.
kind of how you've come to where you are and what you want patients to know about you. So I've got a list of questions kind of queued up here for you, so I figure we can kind of dive right in.
Great.
So what is it that initially inspired you to specialize in spine surgery?
Literally, one night in the emergency room, I was looking at an x-ray of somebody's neck, and the bones were just off by maybe 3/8 of an inch, and yet the man was paralyzed. I can't remember if it was a car accident or he'd fallen from a height, and it just amazed me that a little misplacement like that could completely incapacitate somebody, whereas the rest of my orthopedic training was otherwise pretty brutal. I mean, it was gunshot wounds, car accidents, heavy trauma, so we would have bones sticking out of the skin, we would have pelvises sheared in half, but this seemed so minute, it just amazed me that somebody could then be completely paralyzed. And so there was a technique we were using back in the time, and this is before MRIs, where we would actually physically manipulate somebody's neck back into place, and then all of a sudden, boom, the lights would go back on and they regain their strength. And I thought that was pretty amazing.
Yeah, I would say so. And can you maybe define for anybody who doesn't know just the spine specialty itself, because it's kind of a combination of different specialties in and of itself, is it not?
Well, many specialties care for it, but the spine we think of starts at the base of the skull and goes down to the pelvis, and is composed of bones, which is how orthopedics became involved. And then it's also combined of the spinal cord and nerves, and that's how the neurologists and the neurosurgeons became involved. And then I was the first generation of what's now called spinal surgeons, where they combine orthopedics, neurosurgery, and neurology into one package. And that really, I think, serves the patients best because it brings all disciplines together.
Can you talk about what it's been like to kind of pioneer that?
I can now that I've been at it 30 years, but I didn't quite understand what was happening at the time. But I was amazed coming to practice just how many cases there were that needed treatment. There weren't really, again, that many of us who were trained in the multiple disciplines, so I could see things that I think others didn't who didn't have that benefit of the training. So at first it was overwhelming, and then as more and more spinal surgeons came to the Dallas area, things leveled out and became less demanding.
So can you talk about just in what you were pioneering in the field itself, how you were able to exert your influence and what you feel like you've been able to see change as a result of your efforts?
I don't consider myself a pioneer in spinal hardware, but it was not readily available when I started practice. Where I trained in Cleveland, Ohio happened to be truly one of the areas that pioneered spinal rods, spinal screws, and there was a big controversy going on at that time because these were not FDA approved devices. So we had to go to Mexico, we had to go to Canada to learn how to use these devices in what's called an off-label situation. And since they became FDA approved, that situation no longer exists. But anyway, I was able to make use of that new hardware. I remember going to Mexico with a very talented surgeon there by the name of Eduardo Luque. He actually came up to Cleveland, and so I had that kind of exposure to were the pioneers, the big thinkers, and that's been my contribution, has then been able to teach others, because at many years, Baylor University, I taught many nurses, technicians, and physicians the techniques that I've been taught.
Well, obviously you've taken all that learning experience and you're utilizing it now with your patients today. What would you say is the most rewarding part of helping patients with back pain or spine pain?
A good part of my experience has been trauma. So the ability to walk, the ability to urinate has been probably the most profound, because people who've gone through big traumas like that lose function in their arms and legs and their bladder, and that catastrophically changes the course of their life. But obviously in this section of my practice now, where I'm doing more worn out neck and worn out back problems, it's just relief pain, get off the narcotics, reduce the alcohol, and be more engaged in everyday life.
So for those patients that are experiencing kind of those hardships and they're, interested in coming to you for a consultation, what's your approach in helping ease their nerves and their concerns?
My approach is really just to listen to them, because they've all got a story to tell, and not all of it's good. But that's probably the thing that I do best, which is why I don't sit behind a computer like my own doctors do. I try to look at the patient and talk to them. I have somebody taking notes, because that ability to connect to the patient, I think, is what's most important. And then I start thinking categorically, well, is this a spinal cord problem? Is this a nerve problem? Is this a misalignment of the bones? Is this a poor bone quality? So listening to their story and then fractioning it into the various categories and figuring out what I can treat. And what I've learned over the decades is what I can't treat, because that's equally as big a issue in trying to make the whole person better, what's fixable and what's not.
Sure. Now, what do you feel like are some common misconceptions that exist for patients who come in looking to rule in or rule out the need for spinal surgery?
The biggest misconception is that if I have back surgery, I'm told I'm going to have 4 or 5 back surgeries. And there is some truth to that, but it's much like dentistry. It's rare that a person has one cavity. If you have the genetics or the lifestyle that leads to one cavity, you're typically going to have the genetics or lifestyle that leads to multiple disc problems. So once again, it's rare to have just one disc that's troubled. It's usually multiple. And we have 33 discs between our neck and our back. So about 1/3 of the people who have disc trouble in their low back will have it in their neck or in the mid back. So it's really not the spinal surgery that causes multiple surgeries. It's the disease that spreads to multiple areas of the spine.
So a big part of it, you would say, is kind of being very clear and upfront with the patients and managing expectations from the start.
That's the hard part, is managing the expectations, because it's both hard for the patient as well as the doctor, because I want to help them, but at the same time, we've got to kind of frame this into what can realistically be done. I can't make you into a pole vaulter. Yes, I can change your anatomy, but it's got to be practical. So in other words, if the goal is to walk 2 miles, that's obtainable usually. If the goal is to be able to sit for 45 minutes to an hour, that's a realistic goal. These other things, not so much.
Well, this question kind of dovetails with what we're talking about. What is one thing that you wish that every patient knew coming into a consultation with you?
Well, this dovetails into my advocacy. I'm active in the legislative process, both in Austin and in Washington. And in the last 36 hours, with this healthcare crisis coming up and funding the budget, I've met with 2 U.S. congressmen to tell them what's happening in my office. And so what I wish the patients knew is that this is no longer between you and I like it used to be. There is quite a bit of intrusion by insurance companies and by government entities that kind of restrict what I can do, or even sometimes what I can say. Not so much in Texas, we're blessed to be here, but in other parts of the country it's quite restricted. So in other words, I know, Mrs. Jones, you need X, Y, and Z. I'm not sure your insurance is going to cover X, Y, and Z, or worse than that, they'll cover X, but not Y and Z, so am I going to do a 1/3 of the surgery? That's probably the biggest impediment to delivering health care that I see right now. And there's some well-founded reasons for it, but it's still a problem.
Sure. And what would you say to those patients who, based on those things, how could they advocate for themselves in that case?
Listen to what I'm telling you, and please get on the computer, get on the phone, and call your state representative, your state senator, your United States congressman, United States senator, and express these opinions. And you don't have to take my word for it. Most of the stuff's available on the internet. But at the end of the day, when I go up to Washington, when I go down to Austin, they'll say, yeah, okay, we hear you're talking about a problem, but our voters, our constituents, the 500,000 people in my congressional district really aren't calling me about that. And that's because I think at this stage, patients kind of want the doctor to take care of it, but we're no longer seen in Congress as an authoritative source as we used to be. So they need to hear it from the constituents. And an example is a lady who is got a difficult problem in her neck, and She's been to a number of practitioners. She needs a big surgery, but it's not going to be covered by Medicare. And what I mean by that is, yes, Medicare will say you can have the surgery, but they're not going to pay the hospital for her to stay in the hospital overnight, and they're not going to compensate any of the practitioners, because there'll be about 12 of us in the surgery, fairly, so that we can afford to keep the lights on. So it's as we all know, it's a broken system, and that's really become the greatest impediment to care.
Now, what resources would you suggest for patients who want to be informed on how they can make a positive impact for their own state of care based on the things that you're pushing back on or advocating for?
In the U.S. elections, a little bit different in Texas. In the U.S. elections, 1 out of 10,000 people personally know the individual they're voting for. And the only way to really change is to develop a personal relationship with the staff or a personal relationship with the congressional person. And that takes going to their office, it takes going to rallies, fundraisers, whatnot, and just engaging, because then they've got a face and a name and can start influencing the process. Obviously, the internet can be a good source, but just going to a company's website, the insurance company's website, one can see a great variability between the 4 big insurance companies in Dallas as far as what services they will cover. And there's obviously no way for a consumer to know before they buy the insurance which plan they should go in, because they don't know which diseases they will have. So at the end of the day, get to know your elected leaders, or at least somebody in the office, so that you can start a dialogue.
Going back to what we had been talking about a little bit earlier, as far as your categorical approach, your analysis of the patient and the things that they've said and what they're presenting with, how do you decide when a patient needs surgery versus when maybe non-surgical care would be best for their case?
I always try non-surgical because of 2 reasons. Number one, it's least disruptive to the patient's lifestyle if they can exercise or take some simple medications or just change what they're doing. And surgeries aren't 100% successful. So we try the non-surgical approach first. And as I tell them, it's generally a lot easier if you change what you're doing instead of me going in and changing your anatomy, but sometimes that doesn't work. So the reasons you have to have surgery is you can't sleep. If the pain just gets to the point where you're waking up and don't go into the REM sleep, the restorative sleep, that's one of the big reasons to go. Because after a while, missing that sleep really starts to cause personality changes. It causes high blood pressure. There's evidence that it causes trouble with diabetes. So anyway, can't sleep is a number one reason. Number 2, really just can't work. So you can't provide for yourself. It hurts too much. And a corollary of that is the hermits, those who get up in the morning, go to work, but work just wipes them out so that they crash as soon as they get home, and they're a hermit. So after a while, that starts to change family relationships, it starts to change friendships, it starts to change the way they relate to the outside world. So again, if you can't sleep, if you can't work, and then if you can't kind of do what you want to do, so that goes along with being a hermit. You just have to give everything up. There's the obvious other things, like you can't pass your urine, or your arm is so weak that you can't put your hand to your face, or you're tripping and falling, losing neurologic function, as they say. Those are sort of a separate set of problems where you just got to have the surgery.
Okay. Now, how has spine surgery evolved in the years since you began practicing? I know we talked a little bit earlier about some of the evolution that you saw in hardware, but how else has it changed from what you've seen?
It used to be every Fridays we changed body casts, because after surgery, everybody got a body cast or some form of that. And so rarely do we do body casts now. I haven't put on in 6 or 7 years. And even now, we don't use many braces. So you can think of the hardware, the screws and the rods, as internal braces. So the external bracing is gone because it's being replaced by the internal bracing. That's probably been the biggest change in surgical technique. 2 of the other things has been a focus on nutrition. So medicine is beginning to understand some of the micronutrients, things like zinc, how important they are into healing. And so there's been more emphasis on nutrition, not just the total calories, which are important, but also the amount of protein that goes into recovery.
So we've been talking about all the different things that you've seen evolve over time in spine surgery and spine care. What things on the horizon are you excited about, looking forward to?
One of the things that excites me is there seems to be more of an understanding amongst patients that they have a greater degree of responsibility in their own care. So, I mean, it wasn't that long ago that a third of the people in my office smoke cigarettes, which is known to cause infections after spinal surgery, and at one time was the greatest reason that people built up scar tissue or had a bad outcome from surgery. So better self-awareness. Obviously, there's been a great awareness now of diabetes and the treatment for diabetes, and diabetes is the number one, what we call comorbidity or coexistence of disease that affects spinal surgery. Because patients develop more scar, the nerves don't heal right, they become infected. Then, as we talked about a moment ago, just the interest in nutrition. A calorie is not a calorie. There's a difference between the carbohydrates, there's a difference in protein, and now once again fat is being used, and fat is the substance that coats the nerves, and the nerves are basically electrical wires, so the fat we're eating is used to provide a insulation or a sheath on the nerves in layman's terms.
So we're not demonizing fat anymore is what you're saying?
Correct, we're not demonizing fat. And because we're in Texas, Texas tallow, Texas beef is good.
Yeah. And do you want to tell us a little bit about your relationship with Texas beef?
About a decade ago, my wife and I became interested in being more active in the cattle business. Both she and I had experience earlier in our lives with cattle, and my wife's mother raised cattle when she was young, and so we started doing that. Not that I'm that much of a cowboy, but what I was able to bring to the process is my understanding of medicine, so I can provide veterinary care for the cattle, and also like many big businesses like that, there's a lot that goes on the financial end with commodities, the price of corn, which becomes feed, and the price of natural gas, which becomes fertilizer. So trying to put all those pieces together. But I also just like being outdoors, and I also like the taste of beef, and then began retail sales of beef, which has been a bit of a struggle.
But you say you're not a cowboy, so your patients you don't expect to be wearing a cowboy hat in any other consultations, you're saying?
Don't worry, I wear a cowboy hat a fair amount of time, but not in the consultations. My point is, I'm not on a horse as much as I used to be. I never was any good at roping, and that hasn't changed. But I am in the chutes, I am palpating cattle, I am castrating cattle, I am vaccinating cattle, and teaching all my kids to do so. I think it was important for my daughters to learn how to castrate.
Now, going back to kind of your personal philosophy, can you maybe use 3 different words to describe your approach or philosophy when it comes to patient care?
First word that comes to mind is being fair. That is, this is a human being with a problem that they're entrusting to me to help them with. And so in being fair, part of that is trying to create the right expectation for what can be solved and what can't be solved and just needs to be adapted to. The second thing that comes to mind is I know I must do certain things to maintain a person's trust, and people deal in appearances, so I've got to appear to be trustworthy. And then the third thing is be honorable, and there's a lot of forces in medicine that make some be challenged by that.
Now, in speaking of trust, for the patients who are considering coming to you for care, what is the main differentiator that makes you trustworthy in having patients come to see you over any other practitioner?
To me, it says a lot about a person in business who's been in one location for 32 years. That means I have earned the respect of my colleagues and other patients. It's also, I think, noteworthy that I am not owned by a hospital or I'm owned by an insurance company. So patients aren't directed to come to me as occurs in other healthcare systems. Patients find me by word of mouth.
Or word of video.
Which is my first.
If you weren't a spine surgeon, what do you think you would be doing instead in life?
I would either be a welder or somebody who worked in a foundry. I'm just fascinated by shaping and molding and changing metal. And again, a lot of what I do in the operating room, in my niche of practice, is change spinal alignment. So people with S-shaped curves or twists in their spine, so I'm drilling holes into their spine, and then I'm rotating the spine back to proper alignment using metal rods and a series of levers to lock it into place. So it's the same, changing forms, changing shapes. An alternative would be, I enjoy butchering because it makes a huge difference in how meat tastes and cooks the way it's cut and preserved.
And how is that?
It has to do with the first decision, whether it's bone in or bone removed. The second thing is muscles kind of run in groups. And so the decision needs to be made, are you going to isolate each muscle group like the Europeans tend to do, or are you going to cut across the muscles like we in America tend to do? And depending on whether it's pork or beef, to a lesser degree chicken, the way that decision is made varies. And so as an example, in the United States, we sell pork shoulders as one big piece. But the Spanish have done a good job in individually taking out the pork muscles to either make certain salamis or just straight up. And here in Texas, we also have quite a variety of steaks that you don't see in other parts of the United States. They kind of all get lumped together or just simply ground into hamburger.
How is it that you stay motivated during long surgery days?
A better question is, how do I keep from getting too excited during long surgery days and be more paced? And that requires concentration. So I don't play much music in the operating room because I want the focus on being what my hands are doing. At the same time, sometimes a lot of what I do is monotonous. I spend many times hours under a microscope, so I'm looking straight ahead while my hands are doing this. And it's very tedious with small instruments to dissect out each nerve. So sometimes you want some background music, but motivation's not been a problem. It's been the other way around.
What's your background song of choice?
Older country music.
Anyone off the top of your head?
George Jones seems to get the most airtime, but sometimes we need something a little more uplifting.
You like what you like.
Yes.
What would you say you love the most about your team here at the office?
They're energetic and they're friendly, but probably most importantly, they've learned to focus on the patient, because at the end of the day, that's why we're all getting out of bed, coming in here to focus on the patient. So, I go to my own doctors and I'm treated well, but you can tell sometimes people are distracted working on their paperwork as opposed to looking at me or taking care of the next patient. So, and that's easy in any work, to get lost in the mechanics of what's being done instead of the patient.
Now, Dr. Callewart, what is one thing that you would say that your patients would be surprised to learn about you?
Well, I think that would be that I was the 1996 co-winner of a blue ribbon at the State Fair of Texas for pickled hot cucumbers. These are jalapeno cucumbers.
All right, last question for you. What is one piece of advice that you would say that you live by, whether that be in medicine or in life?
That's changed over the years, but I really do think Jesus was the Christ, the Messiah. So I try to understand the messages he was giving us, and that's what I live by.
And how would you say that you integrate that into your patient care?
Number one, I do charity care because I'm told that whatever you do to the least the little ones do to me. And then also, again, just a sense of being fair to the patient and to the insurance company to try to keep all this balanced.